So good morning again. My second lecture during this course. In the upcoming 30 minutes, I will present you some data from the nuclear medicine physician view on this highly interesting topic. When we talk about the treatment, I think it's all about ions and not the isotopes or whatever, but it's about indications, contraindications, calculations and clinical presentations of hyperthyroidism, and it's good to realize that it's a complete a palette of symptoms, patients, etc. Related to hyperthyroidism. So I will start with the standard contraindications, the standard indications for radioiodine therapy, and I think you all know that the standard indications are, of course, thyrotoxicosis and also the non-toxic goitre. I will not present data on the non-toxic goitre, although there is one slide on it. But this presentation is related to hyperfunctioning the thyroid gland. And from the previous speaker, we already heard that there is definitely a role for radioiodine treatment. One of the most important things we have to keep in mind is that we can choose either between radioiodine therapy and surgery. And there are two comments to be made on that topic. The first one, if you want to achieve very rapidly your results, relief of the symptoms, you can't apply radioiodine. It takes weeks to months before symptoms will settle. And if you are really in a hurry, surgery is the best option. A second comment I want to make is that when you make or have to make a decision either to use surgery or radioiodine therapy, both have the same hypothyroidism rate after treatment. So either you apply surgery or radioiodine therapy, the overall outcome is the same. So don't worry about the topic hypothyroidism. That is not the topic for discussion. The only thing is you have to explain the patient that you can send them to the surgeon, but the outcome is exactly the same regarding the hypothyroidism. Now, when we start treating the patients, in fact, this is the most important slide, because when we talk about the treatment of Graves' disease, you're not allowed to give radioiodine treatment at the initial stage. The patient should put on block replacement treatment, and from the data and literature, we know that 50 to 60% of the patients can be cured by applying this block replacement strategy. Only in case of relapse, you go on for either radioiodine treatment or surgery. Looking at the toxic multinodular goitre or Plummer's disease, there will never be a cure achieved with block replacement therapy. So the only thing is you have to make up your mind when to treat this entity, but not how to treat. So the only thing is you have to go straight towards radioiodine treatment. And what about non-toxic multinodular goitre? Well, it can be treated either by radioiodine therapy or by surgery, and the clinical symptoms are highly indicated for your decision you have to make. When we talk about thyrotoxicosis, it's good to realize that there are two clinical forms of presentation. We have the overt form of hyperthyroidism, but there is also a subclinical form of hyperthyroidism. And sometimes, as a nuclear medicine physician, we forget this entity. You have to realize that also in this case, subclinical hyperthyroidism, we may play a role. And of course, we have the scintigraphic presentations, the toxic diffuse goitre or Graves' disease, the Plummer's disease, the toxic nodular goitre, and the single autonomous nodule. That are the typical scintigraphic entities we are dealing with. Now, what is the overt hyperthyroidism? Well, in fact, it is a combination of clinical symptoms and increased free thyroxine or free T3 levels in combination with suppressed TSH levels. So the standard symptoms may be observed. Sometimes it's only a combination of some of these symptoms, not all. But if a patient is complaining about these symptoms, you have to think about it and do not only the T4 testing, but also the T3 testing. These patients can be assessed for radioiodine treatment, the clinical overt hyperthyroidism. Of course, there are entities also related to overt clinical hyperthyroidism that should not be treated with radioiodine, and these are the two common other entities that can be observed in this respect. The first one is, of course, the iodine-induced thyrotoxicosis or the medication-induced thyrotoxicosis. Some cardiac medicines or drugs can induce this, but also you have to realize that the subacute viral thyroiditis, it resembles the same symptoms, but it is not an indication for radioiodine treatment. As in other treatment modalities with radionuclides, other indications, there are two major or absolute contraindications for treatment with radioiodine in hyperthyroidism. The first one is pregnancy, and the second one is breastfeeding. If you apply radioiodine in these circumstances, you will definitely treat the child as well. So be very careful and ask for that. And at least this is the indication in young female to do a pregnancy test. Don't forget it before you start treating with radioiodine. Of course, there are also relative contraindications. They are also presented in the guidelines. Uncontrolled thyrotoxicosis, heart failure, severe thyroid eye disease, children, but also in planned pregnancy. So if a woman wants to become pregnant, be very careful because she might already be pregnant. Now, the first indication for radioiodine treatment is Graves' disease. And Graves' disease should be treated after a year block replacement. Now, this is the standard picture of Graves' disease when both lobes show increased uptake, intense uptake. But you have to realize that Graves' disease can also be unilateral. Be very careful of that. So in case of hyperthyroidism, you have to perform a scintigraphy to see what's happening, to see what's going on. And of course, it can be a large autonomic toxic nodule, but this is a typical case of unilateral Graves' disease. It's very rare, but regarding dosimetry, regarding those calculations, take this in mind. You can't apply it to the whole gland. When we look at the questions related to radioiodine therapy in Graves' disease, well, the first one is, of course, when should we treat or apply radioiodine therapy? Again, at least 1 year block replacement, but not much longer than that. If there is no cure achieved after a year, the chance of curing a patient thereafter is very, very limited. So stop after a year or 1.5 years and then go to the radioiodine therapy. Of course, another important issue is the patient preparation. Well, according to the guidelines, we have to stop medication 4 to 7 days in advance. So do that. Stop block replacement 4 to 7 days in advance. And then the most important question is, what do we have to give? How much radioiodine do we have to give? And do we have to use a calculated or a fixed dose? Well, we all know that there are two important parameters that in fact establish the final amount of radioiodine. That is the uptake by the gland of radioiodine and the size of the thyroid gland. Regarding the treatment of the autonomous nodule, we have not the same questions. The only thing is when and how much activity we should give. It is highly important in autonomous nodules that when the gland is not completely suppressed, you have to be very careful. You will definitely treat these parts of the thyroid gland as well. So the most optimal situation is a complete suppression of the rest of the gland and high uptake in the nodule, like this, but you still see here some faint uptake. And the other indication, it's Plummer's disease or the toxic multinodular goitre. In fact, the same questions. when are we going to treat the patient, and how much should we apply. And you see here a patient with the multinodules in the thyroid gland, and after that you see nicely recovery of the gland. There is only one thing that has to be kept in mind: avoid treating patients when the remaining gland is not suppressed. So if there are no areas like that in the gland, or there with less uptake, don't apply radioiodine, because you will definitely destroy the whole gland. There is one very, very difficult entity, and when you look at the data and literature, there are not much papers on this, but what about the induction of Graves' disease after the treatment with radioiodine for a non-toxic goiter, or even for a toxic goiter? And we know from the data and literature that 5% of the patients with a non-toxic goiter treated with radioiodine may develop Graves' disease. And the question is, what should we do thereafter with this entity? Should we apply radioiodine treatment again? How much? What can we expect? What is the final outcome? Is there a cumulative effect of applying a second dose of radioiodine? In fact, we don't really know, because the data on this entity are scarce. Now, when we talk about radioiodine, one of the most difficult discussions on this topic is whether we should apply a fixed or a calculated dose. And there are many controversies in literature related to this topic. And the controversies are related to the age, are related to pre-treatment, are related to the administered dose calculation. How should we do that? What should we do? Do we use ultrasonography to assess the size of the gland, or can we use scintigraphy? What about dysthyroid eye disease? Has that influence on which strategy you should use? And we just heard that secondary malignancies induced by radioiodine therapy. Well, I think this is the less important issue in this respect. But be careful if you have to apply more than 1 or 2 doses to cure the patient. Well, the first controversy is the age. When should we apply a fixed or a calculated dose? And when you look at the data in literature, some groups at risk have been identified in which one or the other strategy should be applied. And usually, these data presented in literature favor the use of calculated doses. So the question is, do we have to apply calculated doses to young women? You want to cure them very rapidly, and then thereafter they can become pregnant. Or do we have to use the calculated doses in all adults? And when you talk to the colleagues from the Dosimetry group of the AANM, they support this. Please use dosimetry in all patients, because then you know what you're doing. The problem is, who is doing here dosimetry for treatment of thyrotoxicosis? 4 and 24 hours uptake, you do? You do. Who's using a fixed dose? Well, the standard reason for using a fixed dose is that it's very easy and not time-consuming. You give a standard dose and the patient can send home. Of course, what about children? Children older than 60 years of age? Or should we apply a calculated dose in all children? The data on this topic are still scarce. And again, what about pre-treatment? And how does it influence pre-treatment, the hyperthyroidism, the outcome based on the fixed dose or the calculated dose? What we normally do is that when a patient is thyrotoxic, we start block replacement to stabilize the disease. The problem is that we have absolutely no idea how it influences the outcome of the fixed or calculated doses. And how long should we give or provide the block replacement before applying a calculated or fixed dose? It is really, really difficult. And we know that pre-treatment with block replacement may reduce the efficacy of radioiodine. And another important issue is, that it requires short intervals between uptake, measurements, and the treatment. So if you want to do dosimetry and you start block replacement, you have to stop the block replacement, do within 4 to 7 days your uptake measurements, and within 3 days thereafter, you have to provide or give the treatment. The longer you wait, the longer the interval is between your uptake measurement and your final treatment, the more unpredictable the outcome will be. And that has all to do with the fluctuation of TSH levels, etc., etc. So be very careful. And finally, of course, the administered activity. Well, the controversies in literature, in fact, do not favor one or the other strategy. Can we use a fixed activity? And if we are going to adjust a dose, well, why only by tracer studies and uptake measurements and not by biochemical findings, the antibody levels? And why not adjust it by clinical findings? It is really funny that we are treating, in fact, a number and not the patient. Well, when we talk about the dosimetry, the calculated doses, you see here the EANM guidelines, how to do that. It is highly important to assess the uptake measurements, the uptake of radioiodine at 4 and 24 hours after the application. And again, it's also highly important to know something about the size of the gland. The most or the best test to assess the thyroid gland size is ultrasonography. Scintigraphy is a good alternative. The correlation is rather good, but not optimal. And this is, you can find it in the guidelines. I was one of the co-authors, but you see, 2010, I think it's time for new guidelines. Now, when should we apply a calculated dose? Well, one of the most important things is that you want to avoid a second treatment with radioiodine. If there is an indication for that, a woman wants to become pregnant, you're dealing with children or whatever, I think that there is really a reason to use a calculated dose. But also, what happens in high turnover patients when the uptake at 4 hours is much higher than after 24 hours? We know that the risk of failure is higher than when it's vice versa. And you have no idea what's going on if you do not do such measurements. And also, in patients with an extreme high uptake, for example in Graves' disease, when the uptake is 80%, the risk of failure is higher than when the uptake is 60%. So the higher the uptake, the higher the chance of radioiodine failure. And without uptake measurements, you have absolutely no idea what's going on in these patients. So that might be a real indication for a calculated dose. The question is, however, do we do better with fixed or calculated doses? Well, when we look at the data in literature, you can see here a very nice review paper on the clinical outcomes after estimated versus calculated activities in the treatment of hyperthyroidism. And these patients that were included suffered from Graves' disease or toxic multinodular goitre. And what you see here on this paragraph or in this table, in this figure, is that in fact the overall outcome based on the papers in literature do not favor one or the other strategy. And that means that you can apply a calculated dose, but it has in fact the same result as when using a fixed dose in this subgroup of patients, Graves' disease, toxic multinodular goitre. And when you combine, or when you look at the outcome and combine the euthyroid status or the hypothyroid status, it's even the same. So regarding this respect, in fact, it is very difficult to assess or to establish to favor one or the other strategy. And based on this paper, you can see here the conclusions. There was no difference between the estimated and the calculated activity in Graves' disease, toxic multinodular goitre. There is only one thing to keep in mind. The overall follow-up in all the papers presented in literature are only up to 12 months. We don't know anything about pre-treatment block replacement prior to radioiodine application. And one of the most important issues, as always in nuclear medicine, is the heterogeneity of the population studied. That was studied in Graves' disease and toxic multinodular goitre. Now, what about the autonomous nodule or the single toxic thyroid nodule? This is really a nice paper in which the calculated and fixed dose in this group of patients was evaluated. And you see here the calculated low dose. Patients were treated with a low dose or a calculated high dose with a mean value of approximately 700 megabecquerels. And that was compared with a fixed low dose of 481 megabecquerels and a fixed high dose of 800 megabecquerels or slightly more. And what can be observed, or what's concluded from this study, was that the calculated high dose protocol is preferable in old patients with a toxic adenoma, whereas a calculated low dose is more appropriate in young patients. And you see here the figures, the plots underlining this statement. And one of the most important issues, of course, is the rate of hypothyroidism. The higher the dose, the higher the chance on hypothyroidism. But again, in clinical practice, it is very difficult to favor one or the other strategy. They both cure a large number of patients. That is the calculated strategy. This is the fixed dose strategy. It's just an example how we applied it in clinical practice. Graves' disease, and what we do was just palpate the size of the thyroid gland, estimated the size of the thyroid gland by palpation, and then said, okay, it is not enlarged, we give a low dose. If it's between 2 and 4 times enlarged, we give twice as much up to that. And you see here also the other amounts of activity applied in this example. Why not higher than 1200 megabecquerels? Well, it has all to do with the admission time for a patient. You want to keep it as short as possible, and the higher the dose, the longer the admission will be. Now, what about this thyroid eye disease? Can we avoid this entity by applying a fixed or calculated dose? Has it any relation with a fixed or calculated dose? What should we do when patients present with hyperthyroidism and eye disorders? So the question is, does radioiodine cause this thyroid eye disease? Another thing is, when there is already an eye disease present, does it exacerbate this entity? Well, what we know about this is that TED affects 50% of the patients with Graves' disease. It correlates quite well with the antibody levels. One of the most important things is that it is a self-limiting condition, but sometimes you don't have time to wait for that. And another thing is that there is a protein expressed in the thyroid gland and the eye muscle. They have a shared marker, and that is in fact one of the causes of eye disease in Graves. When you look at the presentation of the eye disease, you have to realize that the patient may present with thyroid eye disease as first symptom. So he may show abnormalities to the eyes. It's only in about 20% of the patients. Sometimes the patient suffers from other symptoms in about 40% of the patients, and sometimes in 40% of the patients, the other symptoms are indicated for hyperthyroidism, which is followed by eye diseases thereafter. What we just heard already, there are some risk factors for eye disease, for the thyroid eye disease: untreated hyperthyroidism, high antibody levels, smoking, and male. That are the most important risk factors for thyroid eye disease. The question is, what about radioiodine treatment? Should we use a fixed or calculated dose? And what should we achieve in these patients? Well, what we know from the randomized trials of radioiodine in patients suffering from this disorder is that we know that radioiodine initiates or exacerbates the eye disease. So you have to be very careful. You have to be very careful when applying radioiodine treatment. And another important issue is that you want to avoid post-radioiodine hypothyroidism, because that seems to be a risk factor for prolonged thyroid eye disease. And that was based on the data in 1994. So, regarding the recommendations of radioiodine treatment, what initially is required is a prompt and effective control of hyperthyroidism, encourage cessation of smoking, so patients should stop, avoid treating patients with radioiodine when the eye disease is active, cover with high-dose steroids if the eyes are still active during radioiodine treatment. Sometimes it's not possible to relieve the complete disorder. And one of the most important things is that we have to avoid hypothyroidism after treatment. And that means that a calculated dose should be applied in all patients presenting with eye disorders. Now the final topic, the last topic, subclinical hyperthyroidism. Well, sometimes we think that it is not a clinical entity. That is wrong. Patients may present with symptoms, palpitations, diarrhea, or whatever. It is not a clinical diagnosis, it's a biochemical diagnosis. And what we normally see is a normal free T4 or T3 level with lowered or slightly lowered TSH levels. And it can be observed in 1% of the population, usually in relation with toxic multinodular goitre. And this is really a nice paper in which a beautiful overview is given on the relation between the subclinical hyperthyroidism and the clinical practice. So if you have time to read this paper, do that. Now the question is, what should we do with subclinical hyperthyroidism? Is there an indication for radioiodine treatment? The answer is yes, and that is presented on this slide. It is according to the guidelines, and what you can see here, that when the TSH levels are below 0.1, in most of the patients, radioiodine is indicated or considered. When the TSH levels are in between 0.1 and 0.5, you can consider radioiodine treatment. So it is one of the options that should be considered in the subclinical hyperthyroidism group. Be careful of that. So nuclear men physicians, you may play a role in this entity. The question is, however, how to treat subclinical hyperthyroidism. Well, it's quite simple. You have to treat the subclinical form as overt hyperthyroidism. You have to do or to follow the same strategy. The question is, however, how are we going to do that? And also in this respect, you have to realize that when you make a scintigram, an uptake measurement, you usually see normal uptake in the thyroid gland. And that has definitely influence on the dose you should apply. Be very careful. So sometimes, or quite often, you see normal uptake. And that is in fact the most important indication in this group to perform uptake measurements and to use a calculated dose. Well, how can we improve the outcome for radioiodine treatment in the subclinical hyperthyroidism? What we can do is apply recombinant TSH to lower the activity. The question is, however, is the dose that we apply then enough to cure this entity? The data and literature are scarce. And the question is, of course, one of problem is that if you start applying recombinant TSH, you will definitely stimulate all nodules. So you will treat more than initially should be treated. And the overall outcome, when using a lower activity, we don't know. Should we pre-treat the patients with block replacement in this subgroup? Maybe, maybe not. And when should we stop? 4 to 7 days in advance, we don't know. We know that in this group, the calculated dose is recommended, but timing, patient preparation is really, really a big issue. And so far as I know, as one of the co-authors of the guidelines, I have absolutely no idea how to handle this subgroup of patients. Now, when we talk about the treatment of hyperthyroidism, there are quite a lot of issues that still need to be clarified, and it's my last slide. And you can read the guidelines. It's still the last paragraph of that paper. What are we going to do with the fixed or calculated activity? What are we going to do with recombinant TSH, drug withdrawal, stunning effect, etc., etc. And again, you see here the use of glucocorticoids, corticosteroids in Graves' disease, when, how much, when to go on. Many questions to be answered, and I think that since 2010, the answers still haven't been found on these issues that required clarification. So in the upcoming years, we will start writing the new guidelines, and hopefully there are more papers dealing with these topics, but I'm really a little bit worried about what we will find. I think that was the last one. Thank you for your attention.